I think that's a very important question, because if a nodule pops up on our chest X-ray or a chest CT, it's most likely to be a granuloma due to tuberculosis. Vis-a-vis in the part of the country where you practice, or in the US, where the concern for malignancy is there. Now, I would guess that, I would propose that the algorithms should be taking the clinical context into well, and it should be geographically robust in keeping in terms of those biases. I think first Indian studies should be done for our own patients, then probably you could extrapolate that to the other.
Absolutely. I think that's a very intelligent question, and it's one of the burning problems which we are facing, because I practice in UK, and the racial distribution of diseases is so different, the demographics is different, the distribution and the types of diseases are very different. See, if you go there, Crohn's disease is so common. Crohn's is not that common here. We have TB. TB is relatively rare in UK. So when you are actually, doing this sampling, you're sampling the data. So it's very important that you sample the correct data, because it's a raw data which is going to give you the answer finally. So if you're going to, study the Indian population and trying to use that software in some other country, it's not going to work. So I think that's the most important thing. And that's why we have so many different softwares available in the market, because people are realizing that it's not a one-size-fits-all. Okay, thank you very much, Eshwar, and to you. I'm going to move on to the next panelist. We have Dr. Milap Shah. So after radiology, it is, ideally it should be the surgeon, but I'm going to jump, because histology and radiology are the most affected specialties in AI. So I'm going by, who's affected most and where AI has made massive inroads. So histology. So Dr. Milap Shah is the head of the Department of Histopathology at Yashoda hospitals here. So I'm sure most of you know him very well. So Dr. Milap Shah, please tell us, you're doing so much work in histopathology. I was quite impressed when I came to know what all you're doing here. And your lab is one of probably the world-class lab which you have in Yashoda Hospital. And you should all be proud working in this hospital. They have invested a lot of money, and it is top class. So Dr. Milap Shah, tell us about what exactly is the burning issue with AI, because you told me that you're implementing AI in a big way, please.
So, okay, so it's with very limited experience, we know that it will not give you the answer to all your questions. It's very good in hematology, it's very good in urine analysis, it's very good in extracting the abnormal data for the biochemistry investigation. But the main crux is histopathology. I think we have Dr. Michael, he is to get the FDA approval for the histopathology for any model is extremely difficult. So if you see the 1,000 models get approval for the radiology, hardly one will get for the histopathology. So that's the key challenge. Because the thing, how much we can rely. The histopathology is not black and white. Every cell is different. It's not the 50 shades of gray, it's the more than million shades of grays are there. So that's where the crux is. And the challenge for us, if you see right now, the AI models, they have trained on a specific questions, whether this is malignant or not, whether this is benign or not. But if you see on a holistic perspective, that's not the answer we want down the line 5 years. We need some common sense. If the AI model is trained to predict this is cancer or not, but right now in the same slide, the granuloma or the infection is sitting, that miss, the patient will die. So we need a common sense to make sure it's not only picks up the key question whether this is cancer or not, it should identify something else is also going on. So when there is a question for the common sense comes, that's where the answer lies. That's what we know as a super intelligence. So next down the line 5 to 10 years, it's all about when the question of common sense, now the super intelligence will come into the picture. So it's not only to get the key question and get the only one answer. We need to have a collaboration between the histopathology, radiology. We'll have a whole lots of molecular data are coming up. So those models which are trained to detect the morphology to the genetic profile of the cancer based on the cell analysis, But those models, if they are based on the genomic data which are outdated, then that model is not good at this moment. So we should not rely. The same thing is for radiology. The brain tumor with the IDH mutation, that's fine. Or lung cancer with the EGFR mutation, that's fine. But it was that data where they're 3 years, 4 years outdated one, where you have compared your cells with the genomic data which were available 4 years back. But entire thing has changed. Every month, new molecules are coming up, new targeted therapies are coming up, new variants are coming up, and it's all tied with the FDA. So the clearance is the main hindrance for us to make sure if we want to use it in a holistic way, definitely we need to get done the regulatory approval. That's our main issue.
Absolutely, I totally agree with you, because it's more or less, histopathology is more or less like, it's not just a question of putting a slide under the microscope and saying, oh, this patient has cancer, this one doesn't have. A second opinion, a third opinion, sometimes similar to radiology. It happens sometimes. You can have, AI can get stuff wrong. Like, I'll give you a small example. In our hospital, it picked up the hair braid of a lady on a chest x-ray as a pan-cos tumor. So, nothing is, without flaws. Everything is flawed, because at the end of the day, it's made by humans, and humans do flaw. So we should not assume that AI is the end of the world, and that is like going to rule the world. It's not like that. AI is just another tool in our armamentarium. And as Milap has clearly raised a very valid concern, for them as histopathologists, they can't be relegated to the past because their input is massive. Well, even if artificial general intelligence comes, or artificial super intelligence, we call it AGI, ASI, all that is coming. So those of you who don't know what is ASI, I work in Milton Keynes research wing in England, and there we have a software where a patient goes in, talks to the software, and then having mental health issues, and the software will say, oh, it's so empathetic. Because initially, there was a lot of criticism. I'm sure you agree with me, right, Michael? So I'm sure you agree, and yourself as well. So they said, oh, it can't replace humans because it doesn't have empathy. A patient can't go and talk to AI. No, that's what a patient wants. When it goes to a doctor, he wants empathy. But now, you'll be surprised, ASI has scored above the psychiatrist. They scored above the psychiatrist. The patients are saying, my goodness, it was so empathetic, it was giving me lots of ideas, giving me lots of advice, it was quite motivating, inspiring. So, so I think we have to be aware of that. So nothing is impossible, but at the same time, we have to be very careful not to overuse or misuse. If you have any questions, please, anyone?